Welcome to the American Academy of Neurology, this special webinar. I'm glad to see so many chairs and business administrators that could make this on a Friday during this pandemic. I hope you're well and coping and doing as well as you can, families, friends, faculty, and dealing with this current pandemic that's facing us all. As you know, the academic Chair's work group has continued to work, and we thought it would be helpful to try to put this webinar together, recognizing that it isn't always the perfectly polished AAN event, but we wanted to try to get as much as possible out to you as soon as we could, and to specifically focus on sharing best practices during this COVID-19. So if I can get the next slide. The panel includes a number of people that have been hard at work on our academic chair and business administrators work group. Jane Check, Associate Chair for Finance at the University of California, Larry Goldstein, Chair at Kentucky, David Greer, Boston University, Andy Josephson at UCSF, Brad Klein, who chairs the Medical Economics Committee and is on the board, and Pierce Korb, Vice Chair of Medical Economics, and Kathy Sila is also on our committee as Chair at Case Western. Next slide. So a few things we wanted to go over. First, I thought I would just give a couple opening remarks regarding some of the AAN resources that we have tried to quickly put together. Like a lot of organizations out there, trying to provide as much as we could, as quickly as we could, to this rapidly moving issue. Then we're going to go through, and I think first I want to preface this as we're not going to be able to probably get through all of this. And the key is to get through some of it and allow for questions. We'll deal with questions in the comment box. We may be able to open up the microphones if needed, but we know it's a large group, and technically these things get tricky. So with a couple things we wanted to focus on, and if we don't get it through all of it today, we hope to have another one. I really want to stick to no more than an hour, because I know everybody has many things on their work plate. So first, some best practices on inpatient care services from the neurology ICU, the neurohospitalist and the stroke unit and stroke care, dealing with telemedicine and telehealth, and both Brad and Pierce are here. They've been doing great work with the AAN, trying to get the word out about quickly and rapidly implementing telehealth and how we can do that in our academic practices. Department management, particularly on communications and remote workforce, which we may or may not get to, and then dealing with visas and visa waivers, which is a rapidly moving issue as well. Next slide, please. So I hope you know that the AAN is doing everything we can to try to get things out there regarding this epidemic. And we're trying to provide resources as much as possible to all of our AAN members and prepare and assist neurologists for this, this pandemic. Many of the things have implications for neurology, and we're doing a lot on advocacy. I'll mention briefly. We're providing practice management guidance for members, including telemedicine, which has gone into hyperdrive throughout neurology practices, both academic and those in community practice. And we are exploring other e-learning opportunities with the obviously cancellation of the annual meeting. We're trying to think of other ways to keep our members fully updated on educational opportunities. And wellness has always been a big focus, and wellness is now even more of a focus, and resilience as our academic departments, our faculty, and many of our members deal with the stress of this pandemic. Next slide, please. So we've set up this website. I hope some of you have seen it. Many of the COVID-19 resources are there. It gets updated quickly, and there are other things that we'll keep listed there. We also will try to keep any recordings of certain broadcasts that are there as this central place for all the AAN resources. Next slide, please. In the Resource Center, there are articles, there's our Synapse forums, there is this issue, the telehealth webinar that I mentioned. There is a Richard Isaacson interview with Sanjay Gupta. There are things for patients, education and research that we're trying to grow, particularly guidance from the FDA and NIH regarding clinical trials, and also obviously a lot on advocacy that I want to mention again in the next slide. Next slide, please. So advocacy has been critical. As you know, the AAN has a whole advocacy group, as well as our political action committee. So we have been advocating for the rapid changes in telemedicine. The webinar I've mentioned, you're going to hear a little bit of that in a very capsular summary. We have written to HHS and others regarding AAN resources. On the March 24th, we wrote at the HHS meeting, advocating for coverage and payment with private payers and coding guidance in the Continuum article, trying to get as much as we can out there for telemedicine and other practice resources that we have been advocating for, waiver guidance, MIPS extension, Medicare advance payments. Next slide. We've also been advocating to make sure that PPE is widely available, both for our faculty, our practitioners, and our residents and fellows. The availability of COVID diagnostic testing. We've signed on with a number of organizations about the immediate need to increase that. Financial assistance for practices, which is there, as well as for academic medical centers. Expansion and flexibility of telemedicine. Other regulatory hassles that we already have been advocating for, which even now are take on even a bigger meaning for getting the prior authorizations waivers reduced down. Timely access to medications and the neurology workforce. Those have always been some of the key advocacy priorities, and even now they're very timely. Next slide. So that's just a background on what the AAN is doing overall. I think what we're trying to do tonight or this afternoon is to just give some key updates and really some guidance from some of the people on the panel. And we know there are many other experts out there that are part of this meeting, and we hopefully will be able to share best practices from some of you. So again, the Zoom tips, and we're all learning Zoom, and there are tips there, and you can be able to see on the participant list, and there's the comment bar to put questions in. I think we have some AAN staff that are monitoring to keep track of certain questions that may come in. So use the question and answer key to ask questions. There's the chat function, and there may be the opportunity to mic up some people. It'd be great if we heard from maybe some colleagues in New York, if possible. We do understand that there are 134 attendees here, so it may be difficult. So why don't we move forward and get started? If I can get the next slide. That we're really going to hear first from David Greer, who's going to tell a little bit about, under these first three subtopics, some best practices on inpatient care, and starting out with the neurocritical care. So David, go ahead.
Great. Thank you, Ralph. If I can have the next slide, please. So I've broken this down into just 4 slides, but sort of some key concepts for people to keep in mind. If you have neurocritical care at your department or institution, then you probably have a neurocritical care chief, and understanding and staying in good communication with that person is really key. They have a very, very hard job, which is very much a full-time job at this time, and trying to keep them as prepared and supported as possible is very important. Try to help them or yourself gain an understanding of all the preparations that are in place. What is the hospital and the ICU leadership plan for the surge? And how will neurocritical care be used specifically? It will probably vary from institution to institution how neurocritical care is used, whether you're taking care of COVID patients or not. If you're anything like us, in most places, your neurocritical care volume before the surge goes down for whatever reason, the stroke volume has gone down across the country. That means you may start being asked to take care of non-COVID, more MICU type patients, such as a patient with alcohol withdrawal seizures that would normally go to the medical ICU service that we now are taking on our service. Have an understanding of where neurocritical care is on the hierarchy of utilized teams. Usually the neurocritical care in most places is pretty small, the staffing in terms of maybe 3, 4, 5 attendings, whereas the MICU and pulmonary critical care bench is usually very, very deep. And so understanding when you do get used, make sure that you're still working at the best of your expertise and within your your wheelhouse, so to speak. You have to consider in your own spot whether neurocritical care is a specific physical space, like your unit is a physical dedicated unit, or if you're more of a shared and amorphous space or working as a consultant. That has very different implications. You have to start thinking early about when do you stop taking transfers such as subarachnoid hemorrhages, LVOs, and they'll probably get into that into the stroke model a little bit, but think about, can you treat an LVO and never admit them to the ICU, send them right back to the referring hospital from whence they came, if you have that kind of agreement. Start thinking about those things now. And regarding your neurocritical care chief, make sure you go to bat with the ICU and the hospital leadership when needed, but use that card sparingly. You need to, as a chair, keep your relationship with the hospital very close and positive. Next slide, please. You start redefining who needs critical care. A lot of the people that we typically used to put in the ICU can probably go to a step down or intermediate care unit, such as a post-TPA case that probably doesn't need to have all the neurochecks done in an ICU. Even hemorrhages, if they're not intubated, can probably go to an intermediate care unit and have active weaning of vasoactive drips. And even stable vented patients can go out as well. Think about how do you minimize the exposure of your staff to COVID or potentially COVID patients, using a single examiner instead of a bevy of people going into the room, using electronic or video evaluations such as iPads on wheels, and then collaborate with nursing very thoughtfully. When we stop going into the room as much, or we're having them manipulate the iPad, and we're saving our force, the nurses may not like that very much because they feel like they're being cows sent to the slaughter, if you will. It's a terrible analogy, but you know what I mean, that people do not want to feel like they are less important than anybody else. And so that communication between doctors and nurses in the ICU setting needs to be really groomed and thought of very carefully. Next slide, please. Your workforce, expect that there will be attrition, and that's for a variety of reasons. Some of it will be due to illness, I promise you. We've had residents and faculty who've already gotten COVID. Thank goodness they're all doing well, but people will be out, and they may be out for psychological reasons also. Be aware of that. Be appreciative of when people step up and recognize it, call it out and say, so amazed at all the volunteerism. They need the pats on the back, but be supportive of mental health issues also, because they will come up, I promise you. Try to work with a leaner team, and when you can, send your workforce home and keep them physically healthy and tell them to isolate and not be hugging a lot of people when they leave the hospital, that they really should be trying to keep themselves healthy. Residents may and probably will be redeployed to help medicine teams, so make sure you have enough of a resident workforce to staff your ICU team as well. And then consider other neurologists such as neurohospitalists who can step into some what are typically more traditional ICU roles, and I'm sure Andy will talk about that in his section as well. Next slide, which I think is my last slide. Big picture, and this is not to scare you, this is just being realistic. Expect it to get really, really bad in the ICU, okay? Don't think about if this is gonna happen, don't think when it's going to happen. It's going to happen, and how prepared can you be now? Expect it, once it does hit you, to get bad really quickly, faster than you think, and exponentially. We are living this now, that we are already running out of ventilators, and 3 days ago I never would have imagined that we would have been having this conversation. Make sure everyone is mentally prepared in advance. I got in trouble for communicating with my staff, sounding too doomsday. Now they're saying, he knew what he was talking about. And so everybody should be prepared. Don't put your head in the sand. This is the real deal. And yeah, it hurts to hear the news, but it's true. Make sure your intensivists are cognitively prepared. And by that, I mean, if you're a neurointensivist, you're not used to treating a lot of ARDS. So bone up on it. And not only bone up on ARDS, but this kind of ARDS, which is very different than the typical kind of restrictive ARDS. These are very compliant lungs. And your intensivists need to be cognitively impaired to take care of really sick ventilator patients. Most neurointensivists get this all hands on deck philosophy. So it's usually a group that you can count on. They're already a little bit twisted, in the way that they think and are willing to be a bit more risk-taking. But understand that everybody needs to be prepared to take on roles that they wouldn't necessarily typically do. It can be uncomfortable, but it can also be an opportunity to build camaraderie within your department. So always try to look for that silver lining. So Ralph, I think I'm done there.
Thank you, David. And we're going to deal with questions after we finish the whole inpatient care section. So if we can have the next slide. We're going to turn now to Andy Josephson, who's chair at UCSF, to make some comments on inpatient services, particularly neurohospitalists. Andy?
Thanks, Ralph. I appreciate it. I've been lucky in the last week. I've talked to many of the chairs around the country. We've been sort of sharing best practices, and I think those have been one-off, so it's nice to do it as a group. I appreciate you having me, Ralph. I'm going to mainly focus on neurohospitalists, but keeping in mind there's tremendous overlap between neurohospitalists, those who see stroke patients, which we're going to get to next, and neurocritical care. So a lot of these themes really overlap, and of course, a lot of the workforce overlaps. I think when we think about inpatient neurology in the setting of COVID, there's really two major goals. One is to increase capacity at the hospital to be able to take care of a surge and more COVID patients. And the second is to preserve the workforce. And David really touched on both of these, and I'm going to take them sequentially. When it comes to increasing capacity, obviously many of us have been asked to decrease our inpatient neurology services, either by shutting down the transfer center, not letting neurology elective admissions come into the hospital, taking care of things that maybe could have been done on the inpatient or outpatient side, like infusions, be much more outpatient focused. And that, as David said, has really led to a decrease in neurology services around the country, in addition to this very curious piece that we've all caught up with, which is, where'd all the strokes go? We just aren't seeing as much inpatient neurology and neurologic emergencies, and that could be for a variety of reasons. Hope it's not, but much of it may be people not wanting to come to the hospital. But at the bottom line is we've made room for a lot of these COVID patients, and I'm sure you've all done that in your hospital. Lack of outpatient care may be a problem for these patients. So even though many of us, including at my institution, we've really ramped up outpatient telemedicine, I think there's probably a subset of patients that aren't getting the care they need. And so I would expect over the next few weeks, despite us trying to tamp down the number of neurologic inpatients, we'll see people coming to the emergency department who are off of their meds, who are sicker than they could be or should be because they don't have that outpatient safety net. So increasing capacity is something I think we've all been doing for some time, but those are just a few things we've been working on. I think there's been tremendous push nationally to think about how we preserve the workforce. This is really important, obviously, for our neurology inpatient doctors. We've got to have neurologists who are going to take care of these patients. But it also is important because increasingly in the setting of the surge, neurologists, inpatient neurology specialists are being asked to be redeployed in a variety of places around the hospital. David mentioned the ICU, absolutely. But at our place, we have backup plans where our inpatient neurologists will serve as the hospitalists on the medicine service, taking care of some of the COVID units. We have some of our outpatient and inpatient neurologists plan to take over the respiratory screening clinic, an outpatient, both video and in-person setting. In the ED, it is likely that there will be a time, and we have plans, and we've already started this, where when a neurologic emergency comes in, rather than having the ED see that patient first, have the neurology consultant go down there first as a means to offload the busy emergency medicine physician. Some of this takes local cross-credentialing, and that's being facilitated in a lot of places. And then a lot of really just simple ideas for preserving your workforce, making sure your inpatient physicians are not hanging out in the same room together. That doesn't seem to make a lot of sense. Keeping people who are off service at home. If you're not working, no sense tootling around the office. We want to keep that workforce healthy. So try to make sure, as David said, those people can be at home. And then, like many of you, we've made extensive plans with both our faculty and our house staff to have big backup plans. Sure, there's a cohort of inpatient neurologists and we need a first jeopardy, second jeopardy, third jeopardy because those people are going to become ill. But we also need to think about people who are traditionally not inpatient neurologists in the department, who can be the backup plan should all of those people become ill. So having extensive backup plans for when there is attrition, I think, is extraordinarily important. We had a group of us, many of whom I can see are on the phone. We had a little email exchange of what are we doing for those individuals who are older, immunosuppressed, or high risk for some reason, pregnant. And I think institutions are coming up with more and more policies. At our place, it's been much more of a, if you identify yourself as high risk, at least until the surge occurs, we certainly give you the option. If you want to say, I'd rather not participate in inpatient world, how can we redeploy you? That's going to be another important part of preserving the workforce. And then finally, and I think we're all dealing with these tips, but how can we preserve the workforce by limiting exposure to patients with COVID and also preserving our precious PPE resources? Easy things, non-urgent consults can wait until a patient has ruled out for COVID. If somebody comes in, and at our place, it's a 6 or 8 hour turnaround before you get an answer as to whether they're positive or negative. During that time, you've got to don and doff a tremendous amount of PPE. If it's a non-urgent neurology consult, we'll put that consult off until we have an answer, keeping in mind 85, 90% of people are going to be negative. Then we can see the patient without using that PPE. Tremendous numbers of video options for seeing inpatient consults outside the room. That's really important. And then, as David alluded to, when we're staffing a patient who is on isolation, even though we may be seeing the patient in the traditional attending, resident, junior resident, intern group, having only one person go in the room to minimize PPE. So, just briefly, those are a few of the things that we're working on in the neurohospitalist world to both increase capacity and preserve the workforce. Thanks a lot, Ralph.
Thank you, Andy. Can we go to the next slide? I was going to make a few comments, and hopefully Kathy Seiler could add a few. I know she's there as a participant, about some issues regarding the stroke service. And some of the common themes you've heard from both David and Andy are true for stroke as well, with a couple little other caveats. Can I get the next slide? As they both implied, it's critical to have the backups in place. We, for now, have created a 3 deep service. So for each of this, neuro ICU, stroke, neurohospitalists, and other services, we have at least the attending and then 3 other backups if the attending was to go out. And as Andy was saying, sometimes you got to utilize people who aren't usually used to providing those service coverages. But as much as possible, if you're a larger department, to try to keep that 3 deep. It definitely means people are going to be doing more time than usual, but we need to have that coverage, particularly if someone takes ill or has just a suspected quarantine that's required. We have the same thing regarding our fellows and the resident service. Some of our residents have also been down due to COVID, and some of them have gone out for quarantine because of exposure. So we have to have the same amount of 3 deep for now that we have been advocating for. The number of strokes are down, and actually we've done some anecdotal testing and anecdotally surveying across the Florida Stroke Registry. It's about 120 hospitals and uniform across many of the community and academic hospitals, both comprehensive and primary stroke centers. The number of strokes that they're seeing are reduced. We don't know why. We're presuming that people with mild or moderate symptoms may be staying home. That may have other negative repercussions later. So there are some public health service announcements that will be going out from a variety of organizations to remind people that if they do have some of the warning signs, that they should seek urgent care. For stroke rounds, I think just as Andy and David said, we're trying to reduce the numbers to reduce exposures and limit those getting ill and falling out. So we reduced the number of people as the service shrunk a little bit on our stroke service. We were able to reduce the number of residents, keeping the faculty and fellow there. And we've enhanced telestroke in-house. Everybody thinks of telestroke as something you do, for the urgent cases across a whole system, we brought telestroke right into the house. And some of it is pretty makeshift, from the simple iPad on the pole to a cart that can be wheeled in. And we have one cart that's stationed in the emergency room CT scanner, where the attending could go in with the fellow via telemedicine and be able to do an exam in the CT scan room. And then we have one cart that we're getting up and established on the floor. Before the cart, though, there's a simple iPhone or iPad that somebody could bring into the room, and then you can do the kind of interactive exam via telestroke to limit exposure. The other thing with stroke is bed utilization. I think David already alluded to this. You know, for a while, every TPA case in the first 24 hours would go to our neuro ICU. Well, we've changed that, and obviously some of them need to be monitored on the regular bed and on the floor. And we're reducing the number of vital sign checks that are sometimes done to, again, reduce exposure among staff. And the same thing with NICU bed utilization and utilizing our stroke unit. For stroke codes, for now, you know, particularly if somebody comes in and it's not clear about their exposure, or if they have any of the COVID-19 symptoms, they can't speak or they're aphasic, we have to, for now, presume that they could be positive or could have been exposed or could be in the asymptomatic phase. So we are trying to advocate for PPE and particularly N95 masks as much as possible when dealing with a stroke patient. And I think that just is, depending on the amount of material that you have available, it's the safest thing you could do if the stuff is available for you to use. There are some other guidelines regarding endovascular therapy, and some of these are coming out and being published regarding doing it all under general anesthesia, but where you should be intubated. And there's talk about trying to intubate them in a surface or a room like in the emergency room or in a room off from the endovascular suite where they can be intubated. And then obviously you're not contaminating the endovascular suite as much as possible. All of the endovascular team that has to be in the room would have to obviously be in full PPE gear. There are some other guidance that has come out. The AAN has guidance, as you know, but there are a couple things. And again, it's rapidly coming out quickly. And there's one that's come out, temporary emergency guidance to U.S. stroke centers during the COVID-19 pandemic. And that's from the Stroke Council. And that's online and available. And this is guidance. These aren't evidence-based documents. They're just some guidance, and they shift depending on other evidence that may come in. And then there's another interesting one that came out from a group on protected stroke, code stroke, hyperacute stroke management during the coronavirus disease 2019 pandemic. And there's some interesting guidelines and figures in there that I urge you to take a look at in terms of dealing with stroke code. And there are going to be more things that will be coming out and some things that will be updated as we learn more. But the key is, like Andy and David said, is to keep things safe for your staff, make sure you maintain that capacity, and to make sure your both faculty and residents are as safe as possible in dealing with the stroke care. I wanted to make sure, Kyle, are we able to unmute Kathy Sila if she's in the audience? She can make a comment or two, if that's possible.
She has been muted.
Looks like I'm unmuted. Can anybody?
Yes, please.
Oh, excellent. I agree with everything that's been said so far. I mean, this is really important that the stroke services, although some of the volume has gone down, that stroke could be at increased frequency in the COVID patients. Certainly in the SARS pandemic, vascular events, MI, stroke, PEs, DVTs, we're seeing at increased frequency, whether this is related to the inflammatory state, an underlying hypercoagulable state, maybe related to the viral myocarditis or atrial fibrillation that complicates the respiratory compromise. It's certainly unclear, but this certainly will pose lots of challenges. We're used to doing stroke codes in the emergency room. Inpatient stroke codes, stroke alerts may be very frequent, but depending upon the size of the hospital, the inpatient team may not be as smooth as the emergency room processes are. I certainly agree with this challenge of aphasic patients or uncertain patients that you don't know and they need to be assumed to be a patient under investigation and using appropriate protection. But just doing a code in your own institution, a mock inpatient code. For example, some of the metal nose pieces in the masks may not be MRI compatible. And unless you actually go through the whole exercise with your own equipment and your own personnel, it's hard to know what potential issues you may run into. Thinking about the stroke patient in their continuum of care, I think is really important. Obviously, the whole ambulatory care has exploded with the relaxation of the originating site restrictions where patients can be seen at home or in a facility. The issues about HIPAA compliant platforms. So trying to access people into acute TIA clinics done virtually would be one option to reduce sending those patients to the emergency room, and using telemedicine to help facilitate discharges to home to help support families who don't want to take their loved one to a facility for therapy. Physical therapists and occupational therapists can also do telemedicine and telephonic visits with patients at home and are reimbursed for these so that families can get more support in this difficult environment. And the opportunities for this, I think, just require us to think out of the box a little bit about how we can use a service to support a patient and a family member.
Thank you, Kathy. So this kind of concludes this part. I saw a couple questions, but I know we have the telemedicine part to deal with as well here, and it is 5:37. Kyle, did you see any other questions come up regarding inpatient services, or should we move on to telemedicine?
I believe that was the extent of the inpatient questions. So I think you would be good to move on to telemedicine.
Yeah, I think we should. I'm sorry about the time, and I did promise that we were going to end by 6 or at least within 1 hour. So let's move to telemedicine into the next section. And again, what we don't finish tonight, I hope that we're going to continue with some other ones in the future. So Brad and Pierce, can you do the telemedicine and give us all a crash course?
All right, thanks, Ralph. Very much appreciated. Can you hear me? Just make sure.
Yes.
Okay, great, thanks. So if you can go to the next slide. Awesome. Well, hello, everyone. Thank you again so much for the opportunity to present on this really important topic of telemedicine remote care in what is a period of crisis. Again, my name is Brad Klein. I'm chair of the AAN Medical Economics and Practice Committee, and it's truly my pleasure to present with Pierce Korb, who serves as the vice chair of the Medical Economics and Practice Committee. And so, as you may be familiar, the Academy has been working, very diligently towards telemedicine implementation, frankly, for years. However, widespread use has been blocked by regulatory, legal, and reimbursement challenges until now. And so, once the COVID crisis came, as you know, we all had to stop on a dime and change our course. As a result, the Academy has really ramped up resources and tools to hopefully address your concerns. And if you haven't visited our COVID or telemedicine pages at least once, I encourage you to do so and then do it again, because the websites do continue to get updated. Next slide. So what we're going to try and do and accomplish in, frankly, a brief period is to help everyone get on the same page as to what's been happening in this country with respect to telemedicine and the coding needed to successfully get reimbursed. However, as frustrating as this is to tell you, please keep in mind that what we're about to discuss is valid as of April 3rd, 2020, and may not be valid tomorrow if new regulations or laws are passed. Also, every state has their own laws and regulations that can impact your specific geography. So nonetheless, we hope that by helping you understand the different approaches of telehealth, how to operationalize it and how to code and bill for it, and where you can find some additional resources, you'll hopefully leave this presentation with some additional skills to help your departments continue caring for your patients as well as remain ideally financially more viable. Next slide.
Great. Thank you, Brad. Yes, thanks for having us. I'm going to go over a lot of material very quickly, admittedly, so we'll have time for questions. And I know a lot of us are in different places when the pandemic hit in terms of where we were in offering telehealth service lines. So for some of you, this may be a review, but for a lot of you, this may be a lot of novel information. When I thought about scaling up telehealth services, I tend to think of some barriers above and beyond the operational barriers that we're all facing in terms of just getting our faculty ready to deliver this kind of care. I look at the idea of licensing and regulation, as well as privacy issues, and then lastly, legal issues. Touching on them briefly, for licensure, the good news is that the Fed said, great, let's expand reciprocity and licensing, because the site of care in telehealth is where the patient is, and a lot of times that's their home. So if they drove down from Idaho to see me in Colorado, not a big deal. I'm licensed in Colorado and that's the site of service. But in telemedicine, if they're in Idaho, that's where the site of service is. So licensing matters. And the issue really is at the state level. Despite the endorsement by the federal level, the states really have a lot of control here. So you've really got to check in state by state with the state medical board websites or the state insurance boards. And the figure on the right is something from the Interstate Medical Licensure Compact that simply pre-pandemic, a group of states that said, well, let's at least expedite licensure across state lines for telehealth services. So if your department has not engaged in this in the states for which patients you often care for, I encourage you to try to expedite that licensure, because I don't think this is going anywhere anytime soon. Next slide. The second aspect is privacy. For those that already had telehealth services in place, you likely engaged in one of the HIPAA compliant end-to-end encryption-based platforms. I'm not endorsing any particular one, but the ones we're often familiar with are Zoom and Video Connect, as well as Doxy.me. What the Fed is doing is for those probably smaller practices, or maybe those academic departments that did not have a platform beforehand, they're allowing for good faith use of other services like Skype and FaceTime. However, the AAN official recommendation is to use a HIPAA compliant platform. And then lastly, and potentially most importantly, is your legal coverage. You can have a license in the state of praxis. You can have even a HIPAA compliant platform, but you want to make sure that you're covered from liability operating in these other states. And because your malpractice carrier may not have that in existence at that time, you got to make sure that you file with those additional forms. I will say that even my institution this morning sent out a very helpful email that covered all of our pertinent states with 3 levels of kind of ability to care for those patients: green, yellow, and red. And oftentimes red meant we simply don't have a malpractice agreement with that state. So again, as patients really look for access across state lines, be careful for that too. Next slide. Then the other issue on the ambulatory side, but also the inpatient side, is our support staff. And potentially we could try to sort of solve one problem with another. And that's, what do we do with support staff that are furloughed or otherwise working from home and kind of looking for new ways to work? Well, why don't we put them to use in trying to help scale up these service lines? You've probably heard this before, but you want to basically send patient instructions to see if they're capable or willing to do telehealth appointments in place of their more traditional inpatient appointments. That can involve sending those instructions, but also testing for connectivity issues, which I'll touch on briefly in just a moment. But again, using that support staff, and honestly, non-clinical support staff can engage in that stage of things. For clinical support staff, what you want to do is try to do as much chart abstraction as possible, especially for new patient visits. You can do the typical things that are often in the scope of practice for medical assistants and scribes, obtaining past medical, social, and surgical history, as well as the other things listed here. In addition, on a personal level, I would also encourage you to abstract prior records or prior data, especially for those new patients, so that you can allow your clinicians at point of encounter to move on quickly after having reviewed the data already available. They can also use these support staff to alert clinicians, sort of the virtual version of knocking on the door in the clinic to let you know your next patient is ready. And then also I would add for post-encounter things that can be carried out by not necessarily the primary clinician, but other people, like delivering follow-up instructions or other education, employ them to do that as well. Next slide. So probably one of the most important things I can share, if you're not already aware, is the other forms of telehealth care. Obviously, most of us are familiar with the standard, which is an audio and visual bidirectional encounter, your typical, video visit with patients. But there are other offerings that I think are important to make sure our patients have access. Now, as you can see here, there's a lot of terminology here, and it typically follows the ability to code and bill for these services, which obviously is important, but also in general, just allowing our patients access during this crisis, if only to decompress the potential overutilization of inpatient and emergent care later down the line, like Dr. Josephson mentioned. So pivoting from telehealth visits, right below that is probably conceptually the easiest one to understand, telephone visits. And I typically view this two ways. One, the way in which we conducted care in general, which was calling up our patients to follow up on test results or care plan changes. This is basically your telehealth visit without video, just calling a patient. I typically view this in a second way now as a substitute, especially for return patient visits or established patient visits, when there's a technical or feasibility issue with telehealth. So I kind of also view it now as a potential first-line alternative to full telehealth visits. The second two categories are a little bit more confusing because they have some coding nuances to them, which in the next slide, Dr. Klein's going to review as well. But e-visits, which are also known as online digital E&M, are kind of like a cumulative increased use of patient portals, in-baskets, in-boxes, whatever you use, basically e-visits that involve cognitive evaluation and management. So you can imagine there's probably going to be, if not already, an uptick in the utilization of these things as our patients are fearful and wondering when their next appointment is coming. Some of these things can be handled in this way. And the nice thing is there's now some coding and billing mechanisms to sort of capture that work, if you will, or that increased work. And then lastly, virtual check-ins are kind of a special category that was mentioned because of the issue of who was going to pay for it. Virtual check-ins also include what they call store and forward, basically asynchronous visits where you can review an image or data and then report back to a patient. Both of these two on the right involve a clinician and a patient. So this cannot be counted towards non-clinical, non-qualified healthcare workers interacting with patients. It has to be your clinicians and qualified healthcare professionals. Next slide. So again, we can think about access and honestly, subsequently the coding in a couple domains. Video, is it available or not? Is it synchronous or real time? Synchronous is what the coding language typically uses. Is it a new or established patient? There was a lot of limitations on what you could offer new unestablished patients. However, even just as Tuesday, Brad mentioned the ever-changing climate, that's changed a little bit as well. So they've loosened what you can do for unestablished patients to your practice, but also established patients have more options. And of course, I'm focusing on ambulatory care or outpatient, but there are some inpatient considerations as well. And then it used to matter more about who is paying. That typically matters a little bit less right now. But as we go to the next slide, Dr. Klein's going to take us a little bit deeper into some of the coding nuances. Next slide.
All right, thanks, Pierce. So I also want to give a shout out to Pierce for all his work to put this PowerPoint together and break down some of the barriers to understanding telemedicine. It is rather complex, and we're all learning this together, frankly. And there's a lot of material to digest, and telemedicine coding can really seem complex, particularly when we look at the official labels and the descriptions that are offered for these codes. And what you see here is also based off of the official guidelines available. So if I may break down the labels a little bit better, as Pierce had already done, I hope it might help you get a better perspective of these codes in ways that's maybe more digestible. So first I need to emphasize that I'm going to be focusing on the Medicare billing and not your commercial payers, not Medicare Advantage, nor Medicaid, because each of these entities have slightly different twists on what you can bill for and get paid. And nonetheless, though, the codes remain the same. So one way to appreciate these codes in the context of your department is to create maybe a master fee schedule of all the different telemedicine codes that are relevant to you, with labels and brief descriptions that make sense to your providers, yourself, and your billers. Then list your payers by your payer mix in columns at the top. Then go through each payer to determine who provides telehealth coverage, including parity with your E&M codes, your audio-only codes, and or your e-visits. And presumably you can get the dollar values for these different codes as well. So let's break down the types of services you might want to consider that are potentially billable, because at least with Medicare reimbursements presently, almost every patient interaction is actually potentially billable now. So when we are talking about telehealth visits, which is the first row that you see on this slide, we're really talking about the E&M services that you have done in the past. The reason why this is the case is that Medicare has now allowed you to get paid parity with your E&M services. Not only does this include the outpatient services, but as of March 30th of this year, it includes effectively all the E&M services you would have normally considered in the hospital setting, even critical care. The second row is in regards to the e-visits, and this is a situation where the patient reaches out to you for questions by secure email or your patient portal, as Pierce mentioned. And if your providers spend 5 minutes or more going back and forth in communications within a 7-day period of time, they can bill 99421. If your providers spend 11 minutes of back and forth in communications, then you could bill 99422. And lastly, if you hit 21 minutes or more, you can bill 99423. This is, again, nothing more than provider time spent in communicating by email or the patient portal. Telephone consultation, exactly what it sounds. It's a patient reaching out to you for a question. And until March 30th, these visits were not paid by Medicare. And until that date, you would have used the virtual check-in code G2012. And this code would have been reimbursed for you effectively for a 5-minute call. However, now that the telephone consult codes are available, we would encourage you to use these codes instead, as there are more options if you spend more time with a patient. A caveat with these codes, though, is that the telephone call cannot be due to issues related to an E&M visit over the last 7 previous days, nor leading to an E&M service or procedure within the next 24 hours after that phone call. So lastly, the value of these virtual check-ins, or more specifically the code G2010, may be valuable if the patient wants to send you an image or record to review. So I'll also caveat, though, that there are several additional codes that you may want to consider, specifically the physician-to-physician consult codes 99446 through 99449. So the value of these codes will be in the context that a physician reaches out to you for a consult on a patient, and you have a conversation, and then you write a report regarding that patient. If it takes more than 5 minutes to have the conversation, then you can actually bill for that time. And if there is no verbal conversation, only a written report that takes, again, more than 5 minutes, you can still also bill for 99451. Now, on a logistics level, I admit to you that even though we've been able to bill for telephone calls through G2012 with Medicare for a while, my practice never actually pursued that, because at the time, not only did you need to get consent from the patient, but you also had to charge them for the coinsurance for that call. And so given the dollar value is still relatively small, the time and effort to try and collect the coinsurance was frankly administratively not worth our while. However, because Medicare has lifted the requirement to collect coinsurance, these codes have become a no-brainer, because we're all documenting the telephone visit regardless as part of providing appropriate clinical care. And then we just need to let the billers know that we provided the service and they can bill for it. So there's lots of opportunities for, again, you to collect on various services that you've been doing pro bono for years, if not decades, that you now have availability and access to, particularly during the COVID crisis. And with that, I'll go to the next slide, Pierce.
Yeah, so because of time, I'm going to sort of very much summarize the next 2 slides, which were essentially a way to say that we're kind of in phase 1, which is scrambling to get our faculty even just ready to engage in telehealth services. And then maybe phase 2 is to try to then approach it in a more systematic fashion as we kind of learn as we go. And so these are very basic, and I don't pretend to have all the answers, but it was really just an idea of how to have a systematized approach to converting new patient and established patient visits into one of these several offerings that myself and Dr. Klein mentioned. And he did mention, you know, for example, what do you do about new patients for which you feel like telehealth is necessary or some sort of visit, and you don't want to send them to the ED because it's otherwise semi-urgent? You know, maybe some in between consultation with the PCP that has the referring provider that had those questions, and then potentially billing for the time in that provider to provider consultation. And so again, I'm not going to, I had 2 slides, and the next slide just refers to RPVs. We can go to that slide now. But again, it was more about having an approach, an appropriateness feasibility. I would encourage you to have a system in place where someone contacts the patients and walks them through your platform, not just ask them if they got high-speed Wi-Fi, but actually walk them through it beforehand. So at least you eliminate that variable potentially before the actual encounter with the clinician. I'm going to go to the final slide again, just to respect everyone's time. Again, I would just sort of say we're standing on the shoulders of giants. There is a wonderful webinar on telehealth specifically during the COVID pandemic on the website that's recorded, and I've watched it twice now, live and post hoc. A couple other resources to point out includes AHIP, America's Health Insurance Plans websites. We mentioned a lot of the variability from state to state and plan to plan. That's one of the best, most up-to-date resources to find consolidated information about who's covering what and what codes are they favoring. I'm gonna stop there unless Dr. Klein has a final comment, just to make sure that we have enough time for questions.
Yeah, there's been a lot of questions regarding the CARES Act, which is arguably separate from telemedicine, of course. There's a lot of talk about the paycheck program, the PPP, and the caveat with that program is if you're not aware, it only works for companies that are less than 500 full-time employees. So for a lot of academic departments, that won't work very well for you, of course. But there are some other opportunities potentially, like the employee retention credit I would encourage you to look into. The other thing to be aware of is Medicare advance payments are available. So if in case your department is strapped, you can actually request from Medicare payments in advance for the patients that you will be seeing in the near future. And then you would just pay Medicare back by not getting reimbursed for those services in the future. And if you weren't aware, by the way, the Medicare sequestration was pulled back until the end of this year. So it's not much, it's 2%, but it is something for all your departments to be aware of.
And there was a question for Pierce regarding consent for e-visits and virtual check-ins.
Yeah, so it was a good question. Consents are absolutely necessary for telephone visits, especially because they're billable. There's been a lot of question and debate about what is consent. I will tell you our experiences is like, let's say I already had a return patient visit scheduled for April. We're calling those patients to find out if they're okay with telehealth. At that point, a lot of our patients are saying, I live in the mountains, I'm not going to be able to have that. Then we simply kind of go, would you be willing to do a telephone only visit? And then we document that consent. Verbal is all you need, but we would then document that to make sure that that counts as consent towards, I'm okay with a telephone only visit. The question about those other two offerings, it is an interesting one. I don't think it's absolutely necessary, but I would, when not known, I would actually try to get consent and document that as well if you're going to bill for cumulative e-visits. Now, again, I don't want to get in the weeds here, but e-visits are something that we used to do, again, as a matter of course. When I get in-basket or inbox messages in the patient portal, I answer them. But if it's an E&M issue that takes at least 10 minutes, or at least 5 minutes to 10 minutes, then you could potentially bill for that. You might want to obtain consent at that point that issue is being resolved during that time. Dr. Klein, did you have any additional thoughts about that?
No, I also think it depends, if you need to do written versus verbal, depending on the state requirements too. So you just want to keep that in mind as well.
So again, thank you, Pierce and Brad, for quickly distilling that down for us. And I know some people are better than others in terms of the amount of telemedicine they've been doing. I know for us, we've gone into hyperdrive to switch all of our ambulatory to telemedicine, and we were kind of behind the curve. I know we didn't have time to hit all the questions, and I had hoped to even be able to get more on our agenda, which we did not be able to touch on. And also there are some, I know out there, some people from New York that wanted to say some things, but I do want to make sure that we end on time. If you can go, Kyle, if you can go to the last two questions that we had.
There was a question about Medicaid in there, about whether or not they would allow for waiver of copay. The good news and bad news about Medicaid is a lot of their loosening was vaguely written to be broad. As you know, Medicare varies from state to state and sometimes even within the plans from those states. So unfortunately, my generic answer is you're going to have to contact your contractor in your state and with your plan about that question. My answer is what I would think so, but again, unfortunately with Medicaid, it's just so variable that you're going to have to ask at each individual state level.
So before we end, Kyle, can you put up the question? There were two questions that we wanted to ask the audience. I think it flashed a moment ago and now it's gone. There we go. Did the webinar meet with your expectations? And would you be interested in attending another webinar? And again, I would like it to be more interactive, so maybe we won't pack an agenda. You know, there were 2 other things on the agenda tonight we won't get to, and we could start with them next time. So I think the key is, Kyle, do they just check the boxes here, and then it will be recorded and we'll get the results at some point?
That is correct.
Okay. So I want to thank again, first of all, the panel members that have been part of the academic initiative. I know we weren't able to hold our Chair Summit 3 this year. We're still hopeful that we'll get everybody together in the fall. We're hopeful that we'll be resilient and get through this pandemic. And we're still trying to be as helpful as we can and provide best practices for our academic constituents out there. I know Jane and others from the academic business administrators that were part of the call tonight who didn't have time to speak up. But I think if we hold this again, I promise to let us hear from some of the academic business administrators about things that they're doing in terms of communication, handling now and a workforce that's working from home, and many of the other things that we're all trying to learn quickly in dealing with the pandemic. So stay safe. Let us know if this was helpful. Happy to hold these again, and we'll continue to provide as many resources as we can to help support academic departments. Thanks to the panel. Thanks to you all for being part of this. Thank you.